They order up a large breakfast. They want to see Mary and Billy and all the people. And that is the scariest part of hospice.
Because the family will be like, they're getting better.
Yeah.
So we warn them about this. I had a patient that hadn't walked in 5 years, got up and walked from the bedroom into the kitchen 2 days before he died.
And it is all full of false hope because they're like, get them off hospice. Daddy's walking. Call hospice. Tell them we don't need them anymore. But that is actually the surge of energy that they need to get out of here.
Welcome to Creepalachia. We have another death episode, but a beautiful one today because we're going to talk hospice with two highly trained professionals in the room. Kelly McFarland, welcome, and Michelle Cook. And we got we did have a chaplain, but he's got COVID right now. Shout out to Tim. Hope you feel better. But thank you all for joining us. We're going to talk hospice care today and what all that involves. So let's do some background first. Let's go with you first, Kelly.
Okay.
So tell me about you.
I am from Cross Lanes, West Virginia. I am the education coordinator at HospiceCare in Charleston. I've been there for 6 years. I was a field RN or case manager for 4 years. And so I teach you how to hospice when you come. I don't know if you want any other background on me.
Sure. Yeah. Where'd you grow up?
I grew up in Cross Lanes, went to Nitro High School. I actually played college softball at West Virginia State University, got a degree in history. And it wasn't until I was 30 years old, I decided I wanted to be a nurse. I became a nurse to be a hospice nurse, and kind of through journeys and different, jobs, I finally found an opening, and I've been there ever since.
Heck yeah. Go ears.
Yes.
What a path. Is there a certain reason you wanted to zero in on hospice over other?
I watched my grandfather pass with hospice, and I felt helpless. Like I was so close to him. I wanted to be able to be there and help him. And I was fascinated by how comfortable they made him and just the process and how kind of beautiful it was. And it wasn't a scary thing. And so when I went to nursing school, I went to Southern in Logan. We did a clinical where we did what's called crisis care. And so I went in and stayed with a family for 8 hours and got to watch that whole journey. And that to me was what nursing was about. I felt like that was what I was destined to do. And so I'm so glad that I have the opportunity to work for hospice, and I absolutely love it.
How nice. I love when people just, know what they're going to do and then they do it. Mine was so far from that. I did not know what I wanted to do till I was late 20s. But thankfully, we're all here today talking about this profession. Michelle, what about you?
Michelle Cook. I'm from McDowell County.
McDowell.
Yes, McDowell County. Been in the medical profession about 35 years, but similar to Kelly, same thing. My grandmother was very ill, wanted to come home. We didn't have any means of bringing her home, and they introduced hospice to us. I personally, even in the healthcare profession, I thought hospice was something you did if you didn't love your family or if you were poor and you couldn't afford to care for your family. Reluctantly, we signed up for hospice, and it changed all of our lives. It changed every life we knew. My mother was an only child. Of course, we were losing my grandmother, but it was a beautiful loss. And we had a part in giving her up versus her being taken from us. So we were actively involved in the process and doing what she had wanted us to do. So I've been there since. I've been 15 years in the hospice world, and recently certified as a death doula.
Oh, sweet. I just had a death doula here recently. So I think that's such a beautiful thing. And clarify this. So people get so mad when I say MACKdowell. How do you say it? Is it, you say it on MACKdowell on one side of the county and then McDowell on the other, or how do you say it personally?
I say McDowell. I just think it's preference. I mean, it's tomato,
right?
Pick one. But in my house, it was always McDowell County. either way, I live in Mercer County now, but McDowell will always be my home. And we provide service in Wyoming, McDowell, and Mercer County. So I still get to work in my home area, which makes it even better.
Beautiful. And, I just say it to get on people's nerves.
Yeah.
I say McDowell too.
I don't think anyone's offended in my county about how you say it. I don't think they care.
Lord, no. Yeah. And so everyone knows that don't. I grew up in McDowell. So love this episode. And it's so awesome having people on. You hear about McDowell from all these outside narratives. You're not supposed to be smart, Michelle.
I know. Well, I found out that I learned something from those patients and those people every time I'm with them.
Oh, yeah.
I may have more information in this part of life, but they certainly know way more than I do. And I've been taught by McDowell County people all my life and continue to be taught every time I'm in a conversation with them. Brilliant people, hearts of gold, biggest hospitality, and the warmest folks and the best patients to care for are in McDowell County, some of them. And so it's just a pleasure to get to be with them as they say goodbye to very, very important people to them.
I love it. Well, thank you all for what you do. So let's get into some details. Kelly first. So the ins and outs of your daily life. Mm-hmm. What is that like? Like, what are you doing currently?
So currently, as the education coordinator, I provide all education from our doctors to our CNAs throughout the hospice organization. And so basically, when you come to orientation, I talk to you about the dying process, the medications that we're going to prescribe, the grief process and how that's going to affect not only the nurses, but the families. We talk about cultural diversity and how we're going to approach different situations, because I'm going to go into, and when I covered in the field, I covered a very rural, low-income area. I'm going to go into those homes very differently than if I'm going to go into a doctor or a lawyer or a mayor's home. And, some of these people may have a third grade education. And so if I need to teach them something, I'm not going to give them the same kind of, well, here's some pamphlets and read over them. Let me know if you have any questions. We meet the patients where they are and where they need to be. And so that's a lot of my role is I bring monthly education to our CNAs, to our nurses, and just it's always continuing education and make sure that they're doing the best job that they can.
Love it. The pamphlets, are they very detailed or you got,
we have a few books that kind of outline what the families is going to see in the last weeks, months, days. And I feel like the more the family knows, and you probably agree with this, the less scary the dying process is. So if I tell them, your mom's probably going to quit eating, and I tell them why she's going to quit eating, and it's not going to hurt them at all, and it's just part of the process, then when it happens, they're like, oh, Kelly said this was going to happen, or some modeling on their legs. Then they're like, well, I already knew this was going to happen. So now I'm prepared for it. And now I know what the next step is. And so it's all about giving the families the tools and the power that they need to care for their loved one at home and make sure they're as comfortable as possible.
Gotcha. And we'll break down those details. Mm-hmm. First, Michelle, what's your day? Like, what's your exact position now and what's your daily life like?
Currently, with the company that I work with now, I'm a liaison, which is basically a consultant. We do much education, as Kelly does. We are the people that connect the doctor, the family, and the hospice agency together, and we bring them all together. So when that patient is diagnosed with a terminal illness, which is defined by something that can't be reversed, basically, then that's when the doctor will recommend that the patient go on to hospice services. So the doctor introduces that to the patient and family. Then the case manager, social worker gives us a call. We come over, we talk to the family. We see if it's a go. It's not always a go. Sometimes they ask you to leave very nicely and sometimes not so nicely. But sometimes they're willing to hear it. So, if you can get past the word hospice, it's a sale every time. It's the word hospice that holds us back.
Right.
And still, all these years later, we're still dealing with the stigma of hospice, meaning we're going to, be bringing death to you
Mhm.
tomorrow. So that's kind of what I do all day. Education, doing lots of interaction with accounts meaning long-term skilled, assisted livings, physicians, hospitals, generally where those referrals are going to generate, and then educating the family until the very last day.
Gotcha. That makes sense. Hospice has always been a verb for me.
Mhm.
And then I just realized recently, is it a company? It's like a company?
Wait,
Or
I
is
think
it-
it's just
is
like
it
you
both?
have neurology, you have cardiology, you have
Specialty.
hospice. It's a specialty.
Gotcha.
So-
Okay. Gotcha. All right. So, Michelle, you have been a bedside nurse, right? At one point in time?
I have been, not with hospice, but I have been in the medical profession, like I say, for 30 some years. I came on in what we consider in the hospice role. Like Kelly, I was wanting to do it so badly after seeing it being done. I just really wanted to know if I could do it or have a part of it. And the position that was open was as a consultant. So I came in automatically as a consultant. So I've never worked as a nurse with hospice, but always been bedside with the patients and the families during the process.
Gotcha.
So
I was a bedside nurse for 4 years before I became the education
Yeah, so
coordinator.
I was trying to remember our messages. I knew somebody was.
Yeah, that's Kelly. And it really, it's team. I mean, we're there also. Education is the tool.
Mhm.
It is the key. If you, we have a little book, one of my favorite books that's very small, written on a 4th grade level, because they want to make sure that families that are stressed to the max can still take in that information. So our company broke that down into the absolute easiest way to understand. It has very little medical terminology in it and lots of common words. So instead of saying, we're going to do that, it says stuff like your loved one will stop eating.
Mhm.
Your loved one will stop drinking. Very easy because
we
they
have a
can't take
book
it
like
in.
that too,
Yeah.
called Gone From Your Sight. Is that the
That's what we
same?
use, the little blue book.
Yes,
Yeah.
the little blue book.
The blue book.
And that's what it's something that it's tangible for those families to have.
Yes.
And when, sometimes they'll say, mom was up all night and I didn't know what to do. So I started reading the book and it opened my eyes. And I think it makes them kind of rethink, okay, this is what I need to do. And that's the hardest thing when I'm orienting new nurses, is for them to switch their brain from a curative method to a comfort. So you think you go to nursing school, you're trained to save someone. And so then you come to hospice and we're like, we're not going to do that. And so I think that that's where the, kind of that, hospice is a bad thing. They look at us basically as Dr. Kevorkian. Like hospice comes in, they give them the morphine, they starve them to death, and then they're gone. I hear that all the time. And it couldn't be farther from the truth.
Right.
So
Yeah, it's, well, at that point, curing is kind of impossible.
Yeah.
right.
It's not an option.
Yeah. So you're going for the comfortability of the transition, which is death.
Yeah.
Okay. I got you. That makes sense.
And we don't make it come faster, and we also don't stop it. We do not hasten or hinder the dying process. We just are there for it, to educate through it. And, you take, every family's different. Every time you walk in a home, it's very different. And a lot of times your families won't even agree. There'll be one medical power of attorney who's making the decision, and the rest of the family's furious at the medical power of attorney.
And sometimes that medical power of attorney lives in Austin, Texas.
Yeah,
and then
California.
you've got all this family here that's like, we're watching mom and she's here. We like to call those family members, they do the swoop and poop. They swoop in, they poop over the whole, crap on the whole situation.
Right.
And then they're gone and the family's left to be like, well, now what? And so we're there to kind of pick up the pieces and be the mediator to say, like, okay, well, mom told me these were her wishes, or, if there's a medical power of attorney, a post form, all those things that maybe outline what they want, we make sure that happens in the end.
Makes sense. What would your all's basic definition of what hospice be for somebody? Like, we know, yeah, you're there when they're dying. But what would you? I think it's way more than that. Obviously, and we're going to get into. But how would you describe it to someone in a couple sentences? Would you say?
I would say it's most like being in the intensive care unit at the hospital. It's specialized care for you and your family. You get to choose what parts of hospice that you want and what parts you don't. We offer our medical director, our registered nurse, our CNA who bathes, grooms, dresses, our chaplain, and our social worker. That's our all of our components.
Okay.
But you do not say you have your own pastor and you don't need ours. You can make your own plan. So it's very customized for the patient and their wishes. The first thing that we ask the patient on admission is what's most important to you? Because after all, that's who we're there working for. Well, what's most important to me is being home and being with my family. Sometimes it's pain control, symptom management. So we start making that a part of what we're working toward. And that's our goal. So every time we leave, every time our nurses leave, they're giving education to that family. My mother, when we were going down that road with my grandmother, she kept the blue book on her dining room table. And when she left, the nurse would say to her, here's where we are on the journey. And this is what we can expect next. And my mother wouldn't let you touch that book because that was like her little map as to how to get my grandmother to heaven and how to be helpful doing that. And I'm telling you, the education alone in that. And I had a patient ask me the other day, what am I supposed to do? Just let her die? And I'm like, yeah, kind of. That's kind of her wish. And so you're only honoring what mom wanted. All the more reason when you're electing a medical power of attorney, you have someone that is strong enough to be your voice in controversy because it's going to come and that they know what you want. Don't wait until your bedside to make those decisions. I mean, I tell my coworkers, I have a book called Living to Go, and it's literally how I want to go. It has everything in there, everything that my family will need when I pass. And I revisit that every New Year's. I have nothing else to do. Take the tree down, worry about, how I'm going to be taken care of if I die, because that changes from year to year. The older I get, the more I see, the more I know, and the more precise I am about the way I want things to go at the end. Most people don't even think about death until they have a terminal illness and it's thrown on them at that point. And we've cared for many people, and we say, the patient passes, where's the funeral home? We ask that up front. They don't know. We haven't decided. The patient's 94. I mean, surely one day you said, I want to go to here when I die. But we don't like that. It's uncomfortable for us to hear as a family. It's uncomfortable. We're like, Mom, you're not dying. Do we have to talk about that all the time? But take that opportunity to learn exactly what they want so that you can follow those orders, because there is great healing in knowing that you did what they asked you to do.
Yeah. Oh, such a good answer. I don't know if y'all know this, but we're all going to die.
Absolutely.
Yeah. And it sucks.
It does.
I mean, we can say that, but also it can be a beautiful thing when you have such compassionate help. I don't know how you would describe it. To me, it's like, I can imagine you're so weak and vulnerable and you can't, I don't know necessarily if your mind's in the right place or what's going on. I'm sure everyone's different, but just having someone there as an assistant kind of would just be such a game changer.
I feel like with hospice and being a nurse, hospitals has allowed me to advocate for my patients more in this role than any other role. And I've done everything in nursing other than I was never a labor and delivery nurse, but I've done ICU, I've done trauma, I've done ER. And so many times, you're doing chest compressions on a 97-year-old that like and I've got them back and you think there's no quality of life after this. So for me, if I was going to describe hospice to somebody, it's giving that person their power back and letting them decide what that journey is going to be. So, and our role with hospice is to make sure they get that in the end. They get their final wish, whatever it is. And it's ever changing. On day one, they may say, because we have both home and inpatient facilities. So maybe day one, they say, no, we don't ever want mom to go inpatient. And then day 65, they start to see, we're having a hard time doing this. We're having caregiver breakdown. We get to say, okay, let's talk about our options, and they can change their mind and send them for end of life. And you have to think hospice is from, and a lot of people don't think about this, from 1 minute old until 100. And the oldest I ever took care of was 104. I know we had a 107-year-old not long ago. So a lot of people don't think about the little ones. And so it's every stage of life. And we make sure they get what they want at that time.
Well, that's depressing. What's the youngest age of a patient that you've helped with?
Since I have been with hospice, 6 months old.
Golly.
Yeah, we took care of an 18-month-old.
Yeah. I mean, we get babies that are born without, they only have a brain stem, and they go straight from, the hospital to our inpatient unit. Sometimes the hard ones, though, are my son is 17 years old, and last year we had a boy that within days was the same age as my son. And so I'm looking at him now as a senior and thinking, this kid was just about to start his life and his journey. And kids, though, are so resilient that a lot of times they're the ones that tell the parents, let me go. I'm ready. And as a parent, you just think, no, we're going to fight. And sometimes we have to step back and say that they know what's best, but it doesn't make it any less heartbreaking when that happens.
Oh yeah. Full depression right now. Oh goodness.
When we get to the patient, it's often, the reality of the patient is very clear. Generally, they know they're dying. Mm-hmm. It's not a secret to the patient. It's a shocker for everyone around them. Mm-hmm. We had a patient whose medical power of attorney, her oldest daughter, was 87. Now, that's a challenge of its own.
Yes.
Mom was in her hundreds, and the daughter herself was 87. So, you're looking at the grandchildren being in their 50s. And, and every day the patient would say, can I please die today? Can today be the day I die? Because they've lived so long and they're exhausted. Mm-hmm. They're actually tired, and they're every day is then a journey. That's why I say there's worse things than dying. Ask them on the end. I mean, most of our patients every day are waking up, upset because they're still here for the most point. They know they're dying.
Yeah.
We have that built in that tells us that. But getting the children to understand it, or the denial of the family members, or dad, just walk another mile, just get more therapy.
They always think if they'll keep eating, they'll keep living. And there's, when you educate them about what harm they're doing, then they're like, oh, I can't believe I did that to my mom. Or, it's just crazy because, like she was saying, a lot of times the family's in denial. When I was a field nurse, I don't know how many times they'd be like, please don't ever wear anything with hospice on it. Don't wear your name tag. And I'm like, I don't have to come in here and say, Mr. Smith, you're dying, but I'm not going to lie to that patient. And so sometimes they'd say, now, who are you? And I'd say, well, I'm Kelly. I'm with hospice. What's hospice? And so I would just say, I'm here so I can treat you at home and you don't have to go back to the hospital. Mm-hmm. And they'd be like, well, that sounds great. Yeah. I wish you'd been here 8 months ago. And I've had several patients that the family leaves the room and they're like, I'm dying, aren't I? And I'm like, well, what do you think? And they're like, I've known I've been dying for a year. But, Susie in there, she doesn't want to deal with it. And I'm like, well, that's for me to have that discussion with. And so we can do it in a way that it's not so, struggling for everybody to deal with.
Sure, yeah. So you have inpatient and outpatient options? So
yes.
There's a hospice branch at the hospital?
No. So we have standalone buildings. So HospiceCare, we have in-home care in 16 counties. And then we have a 24-bed facility in Charleston for end of life or acute symptom management. And we also have a facility in Lewisburg.
Gotcha.
And that's a standalone. Now, we do have contracts with like Roan General and CMC Taze Valley that if there's somebody there that does need end of life care, our nurses can go in and help them with that.
Okay, I'm going to say something really dumb. Would hospitals mainly not want to work with you because they want to keep people alive to make more money?
They are in the curative business.
Okay.
Absolutely.
Okay.
I think that's the PC way of saying that.
And
Gotcha.
they're following a family's command. I mean, when every time that emergency door opens up and that patient rolls in there, that's their request to be cared for. Well, that medical team has to immediately go into action. So a hospice patient rolls through, we make sure that we're giving them a call and saying, hey, our patient's coming through. Here's what we know about them to keep them from falling into that life-saving mode that they're paid to do. I had a physician tell me that one day in a very, very nice way. I said, but the patient's on hospice. He said, well, tell her to quit coming through my ER because we save people here.
Right.
And that's the whole thing. I mean, is it beneficial financially to continue treatment? Absolutely. But can you deny it? You cannot.
Right.
So if that family's saying, sure, dad's 97, but we still want him to have hip surgery, off to hip surgery he goes. Now, the insurance companies are coming back now and saying, wait a second, we're the one paying for that. So we are going to be the one that says if daddy gets a new hip or not. Now, hospice, on the other hand, is paid for by Part A Medicare, and it's paid 100%. It's one of the very few things that Medicare pays 100% of. And so you better bet they believe in something they're paying 100% for.
Gotcha. I bet there's some insurance salesman out there. It's like, I sell Medicaid. I can tell you what Part A is. What is Part A?
Part A is the part that pays for, I think everyone gets Part A. If you pay into the system, you're going to get Part A when you're 65 years old.
What if you're 50 and you need hospice?
If you're 50 and you need hospice, then they're going to look at private insurances. If you have private insurances, some of them pay with some restrictions. Some of them don't pay. We're fortunate enough at my company to be able to take care of patients that we call indigent who do not necessarily have any way to pay.
We do also.
Nice. Okay. So you have certain criteria of like, have so much money and, fixed income, and then you decide case by case, or
no hospice. I know with hospice care, anyone, if you qualify for hospice, we are going to make sure that you are taken care of. You're never going to pay for a med that's more than $5. We provide with all your DME equipment, your CNAs, like your hospital beds, your diapers, catheters, nebulizers, oxygen, all that stuff.
Gotcha.
And like she said, you're going to be provided with CNA services. So somebody can come in and give you a bath and help change your bed and do all that stuff. So we make sure that in your end of life, we make life as easy and effortless as possible. So your family is just focusing on the patient and they don't have to worry about anything else.
Gotcha. Medical marijuana.
Well,
we do
not. I will say we do not pay for that, but we would never tell them not to take it because it is so effective.
You'll sit in the room.
Things.
Don't lie. No, I'm kidding. I'm kidding. Jokies. All right. So, all right. That all makes a lot of sense. Let's say I want to pay cash. What is the typical cost for a hospice?
I've never had anyone to pay cash because they haven't had to. We've had other ways. Medicaid pays 100% also, the state Medicaid. Medicare pays 100%. Private insurances or just the indigent program is all I've ever seen.
Yeah, but I've never had anybody have a...
I'm sure there would be a per diem per day.
Yeah.
I'm sure there would be a rate because that's how we bill.
Yeah.
Is per diem per day. So, yeah.
Well, let me ask this. What's the cost on your all's end typically for do you have like a daily cost?
Yeah. We have a day rate that we charge we bill Medicare or the insurance for. And that includes everything that patient needs to be cared for in the hospice world. So some of our patients may cost $27 a day and some may cost $270 a day, but it all equals out in the per diem rate.
I got you. It just depends on what they're getting.
Right.
Yeah.
Yep.
Okay.
Depends on what care they need.
Makes sense. Fair enough. And that, I mean, essentially, I mean, it's not a hospital, but it's the next best thing. I like how you say curative versus comforting.
Mm-hmm.
I think that's going to resonate with a lot of people. So let's talk about the stages of dying, if you want. Kind of what starts to happen, like you're mentioning people know, like how do they know? What do they describe that as feeling like?
I think, well, first I'll say what it takes to qualify for hospice.
Sure.
So to qualify for hospice, you have to have a terminal diagnosis, a non-curative. So maybe you have cancer and they have said, we've tried everything and nothing is responding. ALS is a big one that we see, dementia, post-stroke patients. But you have to have a prognosis of 6 months or less. Now, that doesn't mean that at 6 months, if you're in hospice, we're like, well, that's it.
See you
there's
later.
the door.
Yeah.
Now, you can graduate from hospice, especially like post-stroke patients, dementia patients. If we have had you for 6 months and we're not really doing that much for you, sometimes people, especially like post-stroke patients, will come into hospice. We provide such good care that they will kind of, start to, creep up there and get better. We can discharge them into a palliative program. And so they can continue curative measures. And then they have palliative, which is another kind of end of life service, that will follow with them until they decline and hospice may be necessary.
So you've had people like, I just assume that's it for everyone. Okay. So you give them like a certificate, like, here you go.
Cake.
You what?
We eat cake.
Eat cake? Oh, that's perfect.
Well, I mean, like
not for me, but most people.
Let's talk about some of the kids path patients. Maybe we get a little one with cystic fibrosis, and they're the great things, or we call them kids path, and that's from day 1 until 20 years old. And so if they come to us and they have a possible terminal diagnosis, they can continue curative therapy, and we kind of set on the back burner and we support whatever they need. We, if they need additional equipment or supplies, we can offer that to them. Maybe they need bereavement services or therapy. We can have a counselor go in. And then maybe those curative methods aren't helping anymore. We step in if they need end of life. We've had some little cystic fibrosis kids that end up graduating, and now they're in their teens or their 20s, and so
it's awesome.
Yeah, it really is. And sometimes there's happy stories from hospice.
Yeah. Well, I see it. I mean, obviously, a lot of them are, I'm sure, devastatingly sad, which we'll get into, but I see it as a beautiful thing. Like what a world where we have someone who can do this. And you know what I mean? Because let's be honest, a lot of people, I wouldn't trust the color of coloring book. To be honest, I'm just going to be honest.
Yeah.
Now, there's a lot of smart people out there, but a lot of people just don't know things. You're not going to know necessarily what to do. So yeah, this is a very big blessing to have. All right. So terminal illness, check.
6 months or less.
6 months. Yeah. So, and we talked about, qualifying for it. Typically, you all haven't seen anyone that has to shell out the cash.
Yeah, no.
What's next? Do you just start by, kind of a case by case basis of like, well, what are their needs? What's their illness? And then kind of building the plan around that? Is that?
Yeah. When we get those medicals and a referral, we have to have a doctor's order to start our process. So the doctor writes the order after he talks to the family and they say, yes, we would like to do that. Then the doctor writes the order. And what he's signing is a certificate of need or certificate saying that of terminal illness, which says the patient has 6 months or less to live. Now, that means if they continue to decline at the rate they have been declining. So 6 months, 1 day, we're going to show back up and we're going to look at you and see if there has been a decline from the day we met you until now. If there's a steady decline, you're going to stay on hospice. You're going to qualify. If you start improving and you're not making any declines, then you're going to get discharged back to your home health or to your regular PCP. That happens. It's always wonderful when that happens. So anyway, at that point, we get that referral from the physician along with your medicals. In the medicals is telling us who you are, what your diagnosis are, what your medicine list is, those kind of things. The important thing is, and you have to ask yourself this on every referral, is this patient seeking curative treatment or are they ready for comfort care? That's the two categories that we're looking at on a terminal patient. Do they want to continue to get this chemo? Many times they do, but the body's too weak to take the chemo. So they'll come on hospice, and if they get stronger, they'll come off hospice and they'll go get their chemo. The reason for that is the insurance company is not going to pay us to provide a service and provide a doctor or a chemo to happen in the same day. One of us is not going to get paid. Mm-hmm. So we're very careful in our world to be the first one to say, let's get you off hospice so you can go get your treatment.
Got it.
You can do that. Sure, you can do that. And if you don't get better and it didn't make a difference, you can still come home and come back on our service. Now, we don't want you doing that every day because we have to think about your mindset. Are you really ready to just have comfort care? But at that time, we're working on those physician's orders. We call the family. If the patient is able to give us information, then indeed we talk straight to the patient. If the patient is past that, we start looking for the medical power of attorney. Very important document for all of us to have after 18 years old. That becomes your voice. Who's going to give us instructions on how to handle this situation? Well, we have 11 kids. Well, I need the medical power of attorney. Oh, it's your ex-sister-in-law. We've had it happen. Mm-hmm. Sorry, kids, this is who's going to make the decisions for us. And so we have to legally go and talk to them. What do you think? Oh, I think it's a great idea. Then we roll our team in to do the assessment and the admission. And then they are officially on hospice services.
Got it. Wow.
And if you don't have a medical power of attorney, they will appoint a healthcare surrogate. Yeah. And sometimes that can be scary because sometimes the doctor's just looking at either who's in the room with them or who's on the contact list. It could be an ex-husband. It could be, a neighbor. Yeah. And so medical power of attorneys are very, very important.
Mm-hmm. And children, they go with the oldest child. If there's 6 children and the baby is the caregiver, all 5 of the other children have to say they don't want to do it to pass that down. So you're really playing a lot of games to try to get someone.
Can you have them play paper, rock, scissors?
Yeah, well, I would really like to some days.
Like a tournament. All right, let's go. All right. Yeah, play Uno. Let's go. All right. But all right. Well, that's all good to know. So, and I don't know, Kelly, if you want to take this one or whoever, is there a decline? Is there a checklist of okay, well, they're doing this more than they used to, so that's a decline?
Yes. So once we have them for those 6 months, so at the 3-month mark, we do kind of a reevaluation, see where they are. So we know, are they declining? Or do we maybe want to keep them on our radar for that 6-month recertification? So we look at things like, one thing that we do, because a lot of our patients can't get up and get on the scale, is we will measure your upper arm. And so if I was coming out to do an initial assessment on you, I would measure your non-dominant arm. And you measure from the bony prominence in the elbow to the shoulder midline. And I can measure it there. And then the nurse is going to go in once a month and measure it. And we can see if you're losing weight, even if you can't get on the scale. So we're going to look, are you losing weight? And maybe you're still eating. Has your appetite declined? Mm-hmm. How's your mobility? Are you having any new onset, symptoms as far as agitation, pain, shortness of breath, nausea, vomiting, constipation, diarrhea? As long as we can show a decline, you can stay on hospice. I had a patient for 3.5 years on hospice because she continually declined. She was a 30-something-year-old with early onset dementia. Mm-hmm. And she went from being somewhat able to, she could feed herself, to an infantile state in those 3 years.
perspective, do you all ever want to wring people's necks?
100%.
Okay, for their complaints that they have when you I mean, not the patients. I'm talking about someone's out like, can you believe my chicken nuggets were cold? I can't believe.
I'll tell you what I would like to wring people's necks is when a patient has told their family what their wishes are and their family will not comply or won't give them comfort meds but sometimes I do. We see so much every day and so much loss that I think you reevaluate the way you look at life and you really find the important, those little moments, and so sometimes it's like when people are complaining about these first world problems, like my chicken nuggets are cold or...
I mean, it's a problem.
Yeah. If you ask my 17-year-old, he would 100% agree with you.
Oh, yeah.
But sometimes you just want to say, like, if you had come from, the 4 patients' houses that I saw today, that wouldn't matter to you, you know?
Yeah. Well, you all are so ground level. Like the empathy, I think, is hard to resonate with people because we're looking at screens so much and we don't necessarily know what it feels like to be in these situations. But you all are witnessing it, probably every day. So I just imagine your perspective on life, I'm a sensitive baby. I'll hug my cat and cry for 3 hours because I don't want it to die in 9 years.
Yeah.
Like stuff like that. But I'm sure some jobs you have that ground level perspective on a daily basis. And I'm just curious what that does to your thoughts. Like, do you get complacent working in hospice or do you, what do you love about it?
I love that every story has a different ending. And the ending that one family is looking for is not the ending that the next person's looking for. But when it's over and the patient has had what we consider a good death, it's so rewarding to know that you were able to play a role in getting them to where they're going and they did not have to experience it in excruciating pain. They weren't miserable in symptoms. The family had a good idea of what was going on. And you see that person leave here, but you see that family come together because they've been working together now instead of working against each other during the hospice time. And that's very much what we teach. You cannot do what I do every day and not know that there is an afterlife, that people are going somewhere when they leave here. They're very quick to tell you where they're going. Many times patients will say, I want to go home. And the family thinks they mean to 116 Smith Street, but that's not at all what they're telling them. They really want to go home.
Or they'll see my favorite thing and something that gives me a lot of hope is dying patients always see their loved ones that have passed. And that can be, at my job, they call me the crazy cat lady because I have rehomed and rescued all of my patients' animals. And I know how important mine are to me, but I've even had patients that they see their animals that have passed, their moms, their brothers, their uncles, and have full conversations with them. And so, is there an afterlife? There's something. There's somewhere that we are passing through. And I know personally, when I was a teenager, I had an uncle that committed suicide, and it weighed heavy on my grandmother because she was a very religious woman, and she didn't know if she would get to see her youngest son. And so my grandmother lived with me, my husband, and my kids for 5 years because she had advanced dementia. And about a week before she passed, she had a full conversation with my uncle. And so that gave myself and my mom and my uncle closure, knowing that she at least got to say goodbye to him. She at least got to have that. And so I'm not a very religious person. I'm a very spiritual person. And so just we see way too much on a daily basis not to believe that there's something after this life. So
yeah. Well, and I'm an agnostic person. I think there's such a beauty to a person that really believes in their faith and the empathy and beauty behind their faith, and they just know what's going to happen. I think that's so incredible.
100%.
Yeah. So,
and a lot of times, I'd say to my patients, a lot of times is, it's a pleasure to get to walk you home. And that's how I feel. I feel like that's what we're doing.
Yeah.
Is we're walking them home. No one should have to walk alone. And I believe that when it's time, that someone comes for you. I don't think you have to go alone wherever you're going. I don't think you go alone. I think someone comes there, and that's the reaching and the grabbing that we see, the conversations that go on. And, the scripture that supports that in the absence of our chaplain is to be absent in body is to be present with the Lord. So the philosophy is that patient spends more time where they're going and less time where they are, because it makes it easier to separate from the soul and the body. And so we see that time after time after time and after time until you're like, it's got to be something. They're going somewhere. I mean, I don't know where everyone goes. I don't know that. But I do know that they know where they're going, or they seem to have an idea of where they're going. So it is a beautiful thing. I've seen some really tough deaths, and I've seen some beautiful deaths.
I think how you live your life is how your final journey is. So, I laugh. I had a patient, and he was the human embodiment of a little Banny rooster. I mean, he would have fought anybody. He reminded me kind of like Yosemite Sam. He was just always ready to go.
Right.
And so I've had everything in place. We tried our best to make him as comfortable as possible. And he, even unresponsive, fought us every step of the way. And his granddaughter was like, I wouldn't expect anything less. And I loved this man. I mean, he was a pain in my behind from the minute I walked in there, but I missed him so much. And I missed his energy when he was gone. And I had somebody ask me the other day, how do you do this day in and day out? And I'm like, these families have allowed me to come into their home and made me a part of this journey. And I love my patients like I love my own family. And I hope that anyone that I have taken care of their family understands that. And I feel like when you come, hospice is one of those things, you're either born to do it. I don't think you can learn to be a hospice nurse. It's either in you or it's not.
You have to have that foundation, and then the training is the easy part.
Yeah,
you gotta
exactly.
have the inclination to want to be involved.
The calling,
right?
The ministry, the care, it all comes together. And that is the thing. When our team launches a patient, when we admit a patient, everybody has their favorites. I like the spicy folks.
I like the
people who have it all planned out and they're just following it. And the kids are like, don't ask, just do it. That's the way mom wants it. I like those people.
Yeah.
Those are the easy ones.
Sure.
But you have the difficult ones too. And people, ask all the time, do you just stop crying? And I say to the people I work with and many of my accounts, the day I don't feel it anymore is the day I have to go home because I can't be effective. How can you watch someone lose something so precious to them and it not bother you? So do we cry? Absolutely. Does it hurt? Absolutely. And our nurses, they'll go pronounce and cry to their next patient, wipe up and go in and take care of that patient. I do notice in our world when we have a passing that our team, and I'm sure your team does too, they're like, I'll go pronounce. Because they're connected to that family. Some of them cannot even be on call or working. And when they call when that death happens, they'll get up out of their bed 1:00 in the morning to go help say goodbye to that patient. So it is way more than a job. You couldn't do it if it's just a job to you. You're not going to do it long.
Yeah. And most people, like when I always, we do orientation every 2 weeks. So when I get a new class of orientees, I'm always like, so what brought you to hospice? I like to hear. They usually have, most people say I was drawn to it. And that was like watching my grandfather go through it. I felt helpless. And then going through nursing and really getting to see what hospice was about. I always said hospice was like the unicorn of nursing. You heard all about it, but you never really got to see it because there were people have worked at my company for 30 years. And that says something about a company when people don't want to leave. And I would say my moment was I went through orientation and I got my patient list and I was like, I need to be here. I don't know what it is, but I need to be here. And there was a name on the list that I recognized. And when I went into the home, I said, was your husband a doctor? And she said he was. He was a labor and delivery, or he was an OBGYN. And I was like, he delivered me.
Oh, wow.
And she was like, did he really? And I was like, yeah. I was a high-risk birth in the late 70s. And I said, he delivered me. And I'm shocked that I lived. And she said, well, I was his labor and delivery nurse. So I would have been in the room when you were born. And so I had a really good relationship with him. And our last lucid conversation, he said, let me have your hand. And we were talking. He said, I don't have much longer. And I was like, I know. And he said, I truly believe that I brought you into this world so you can be my angel on the way out. Oh. And at that moment, I was like, I'm exactly where I need to be. Mm-hmm. This is why I'm here. And I still am close to his wife. And so it was just that, that was that moment that I thought, this is exactly why I'm doing what I'm doing. So, and I know a lot of hospice nurses have moments like that.
Yeah, that's beautiful.
Yeah.
And to clarify, you all cater to people's own belief system. You're not like, okay, we only accept this, and this. Okay.
No, there's no, we have every, and our chaplains are geared to minister to every one of those religions. They know exactly how to take care of that. And our chaplain does an amazing job as well. Yes, they have to, it's the religion of preference or not.
Right.
Mm-hmm.
So we honor that as well. We're there, we're in your home. We're going by your rules. Mm-hmm. And certainly we're making sure that you have the support spiritually that you need or don't need.
That's beautiful. Well, all these experiences, I mean, we can't write off everything as coincidence.
No.
There's just so many of them, and there's something to it for sure. I don't care what anyone says, but yeah. So the stages of there's been nurses that have done this for years that are like, they're going to pass tomorrow. Mm-hmm. How do you know that? How is that possible to know those stages?
There's something called a Palliative Performance Scale, or a PPS, that we gauge. And it's from, in the room here, we're probably a PPS of 100 to a PPS of 90. Maybe you have some aches and pains. You're still able to do everything for yourself. And it goes 190 down. Usually you cannot be a hospice patient higher than like a PPS of 60. Mm-hmm. And those are people that can maybe still shower, but it's taken them longer. Maybe they can still make their own meals, but they can't clean the kitchen up. They can't go out and work on the car or mow the grass, but they can do, they can piddle around the house. And so it goes down. And so what we watch is, what's their mobility like? How are they eating? So in the last stages of life, or when somebody becomes imminent, they're going to quit eating. And so once somebody has quit eating, we're looking at a couple weeks. Once they quit drinking, then we're looking at probably 7 to 10 days. And so, I remember starting out and being like, man, Amanda or these nurses that were training me, I'm like, I'm never going to get there. And then, you get to that point where you go in and you can say, because every family wants to know how much longer, how much from day one, how much longer. And they always think their family member is the sickest in hospice, and you want to be like, they are killing it right now compared to, the other 3 patients I'm going to see today. Mm-hmm. So we usually can we know.
Narrow it down.
Yeah.
And everyone, every nurse is different, probably has more of intuition with certain things. The way it was described to me, so the eating thing, why it's bad to do that when they're not, to force feed them, is because it could cause them to choke.
Yeah, they could aspirate. Mhm.
Okay.
And the body is so smart; it knows when it can no longer get rid of that food.
Mhm.
As we start shutting down systems, that what was once good for us is now bad for us. So that body is like, I can't process this anymore. So turn off the appetite button. So you don't feel that anymore. Even
Mhm.
with a common cold, you don't want to eat. That's the body's way of saying, I can't get that out. So I'm not going to take it in. Same thing with fluid. And like you said, you go from a regular diet to bites and sips.
Mhm.
So that's a word that we use a good bit. I mean, how is the patient eating? Well, here and there. And it's bites and sips.
And decline can be showing like when they were admitted, they would eat 100% of 3 meals a day. And then now they're eating 45% of 2 meals a day.
Got it.
And, it's like, well, they're still eating, but it shows that decline. And one major thing is that I know our company, we try to never just say like, well, no, we're not going to do that. Because if you say that to a family, they're immediately on the defensive.
Oh, yeah.
It's like, you're going to take mom's meds away.
Mhm.
So what we try to do is say, well, now listen, we're not going to give them this, but this is what we have to offer.
Mhm.
We're not going to do this, and this is why. So like with the IV fluids, if you talk to a family about what's called third spacing, well, I can pump all the fluids into your mom that we want, but it's not going to go where we want it to go. It's going to end up in big pockets under their arms in her. So she's almost going to dry drown because we're smothering her. And another kind of little known thing with hospice is we do offer some, like, if you have throat or mouth or tongue cancer, you can have palliative radiation to shrink those tumors because we don't want you suffocating. If you have ascites and you have that fluid on your belly, you can go have it drained. If you have fluid in your lungs, you can have that done. So if we can show that some of these procedures, even blood transfusions, if you're severely anemic, but you still have months to live, we don't want you to be drained and just have no quality of life. So you can still have those as long as they're beneficial. But at some point, all of these things that, your body is on its way out, and we need to kind of honor that. And make you as comfortable as possible.
You ever got any weird requests? Like, I'd really love a pack of cigarettes right now. If y'all just go do that.
Oh, yeah.
Oh,
all the time.
Oh, yeah. 6-pack of beer.
well,
Yeah.
I had an ALS patient one time, and he was declining really quickly, and he was having a hard time swallowing. And he said, I'd give anything for a beer right now. And I was like, why can't you have a beer? And he was like, well, I'm on hospice. And I'm like, all the more reason for you to have a beer.
Right.
And he's like, are you serious? And so his wife went out and got him a 6-pack of beer. And then he wanted a BLT with a specific kind of tomato. And the social worker found one at Grits Farms, and we made him his last meal. So in hospice, if you're a smoker and you want to smoke, just don't do it with your oxygen on.
Yeah.
So we're never going to tell you not to do something.
Right.
I say when I'm 90, you better give me all the chocolate cake and like anything I want.
Sure.
But families still will be like, well, now mom can't have that because her cholesterol's up. Okay, mom's 99. And, mom's okay. So.
No, that makes so much sense.
Yeah.
All right. So labored breathing, is that a thing?
Mm-hmm.
Like, is that part of the scale? You hear about like a death rattle.
Yes.
Stuff like, what is that exactly?
So what the death rattle is, or we just call it noisy secretions, is basically, you know how you clear your throat? Well, at the end of life, you lose that mechanism. So it's like a teaspoon of fluid that's just setting right here, and it sounds horrible. It's so hard for the family to hear it, when in reality, if they would just reposition them a little bit, it will help that fluid drain. And we have meds that we can give for that. It's just basically your body, you don't have that cough mechanism anymore. So if you're not swallowing, you're not going to have that cough mechanism. And so that's what that death rattle or the noisy respirations is. And you will start to see what we call Cheyenne-Stokes breathing, where it's that snore-like respirations, or they'll have apneas where they'll take a breath and then they won't breathe for sometimes up to a minute. And And we try to prepare the families so that it's not scary for them.
They say that time is where we get the words playing possum.
Mm-hmm.
That they actually practice dying to see who's in the room and how they're going to handle it. And at that point, that they'll practice it. And if everybody just sits back and says, it's okay, you can go ahead if you need to go, then they'll go ahead. But if someone screams, then it throws them right back into because no one is, think about it. You're not going to die in front of your kids if you have any chance that you cannot. And if someone overreacts every time, they generally wait till that person leaves and then dies.
And that's a big thing.
Yeah.
Patients know a lot of times when they are going to die.
Yeah.
How do you press that button though?
I don't know. And it's funny though, because I had a patient one time that we had her on hospice for a year and we had to discharge her because she was doing so well. And she was like, well, I'm sorry, I didn't die fast enough for you. And I'm like,
sorry, I let you down.
Yeah. And I'm like, I was trying everything, all my, my bag of tricks. I don't know. I mean, it's crazy because you'll have patients that will hold on for days until maybe a family member gets home or a family member leaves. And within seconds, they're gone.
Mothers like their children to be in unity.
Mm-hmm.
There's nothing that keeps a mother struggling longer than her children being at odds with each other. They generally like that. Most of our hospice patients are women.
Mm-hmm.
Women like closed, nice packages. They like everything done. It's not uncommon to see women on hospice that's getting Christmas cards ready for next year, gifts ready for the kids.
I think women hold on a little bit longer because a lot of times they're the cornerstone, mamas, and they're the ones that they get everybody together at Christmas. And so, I always talk about like the grief process. They're grieving what's going to happen to their families.
Right.
Just like their families are grieving losing them.
Mm-hmm.
And so sometimes they hold on a little bit longer because I think they're afraid to see what's going to happen with their families.
Why are majority of the patients female? Is it like a pride thing?
I think if you tell a man he's going to die, he just does it and gets it over with. Men die pretty quick. I mean, they're like, well, what's left of me? They say I'm dying and they pretty much die.
Right.
But the woman, they like a done deal. They like they need to know they've said goodbye to everyone, and they have just the checklist because I do think they're leading the family most of the time. They're in charge of their children and how their children will grieve. They'll take. I mean, I've had some crazy reactions or requests from dying mothers for their children. Now, I want you to go down to the funeral home and I want you to take your camera and I want you to show me the caskets that's available and then bring it back. And I mean, they really like to be in that much control.
Have they ever been like, whatever they do, don't let Timmy control the finances?
Oh, yeah.
Yes.
Oh, yeah.
We hear about all of that.
Okay.
And it's a proven fact that widows live longer than widowers.
Yeah.
Like if a wife dies, a husband doesn't have the support that the wife does. Wives have friends. They're closer to their kids. So they have more support. And a lot of times they flourish even with, their love dying. Whereas, unfortunately, men keep to themselves and they're not big on talking about emotions and all that. So they'll go pretty quickly.
Not me. Shoo-wee. I do it too much.
Checklist.
Yeah.
Hours of ramblings. All right. So tell me about a time, start with you, Michelle. What's one of the most meaningful times you've been at a bedside? Is there anything that comes to you in particular of a time where you're like, whoa, that was special?
Yeah. I mean, I've seen many, many, many times that you're like, I've never seen that before. I mean, you drive all the way home thinking, I thought I'd seen this all. But no, I did see a patient one time and the lady was completely comatose. She knew nothing. And she sat straight up in the bed and she has this huge smile. And her daughter across the room said, "You see Daddy, don't you?" She reached her hands out like this and died.
Goodness gracious.
That quick. And they had just got her off the ambulance and brought her in the house.
Wow.
And he must have been waiting on her. But I mean, she raised straight up and was laughing. And he was there to walk her home. And so, I mean, you do see things that you think, oh my gosh, did that just happen?
Mhm.
We had a minister not long ago who had been, really in the service and had really committed his life to doing that. And he led his family in his death. He would tell them, this is what's next. Just like we normally see a woman do that, he took full charge of that with his family. And he had been a tent evangelist, and so for 40 years. And when he was close enough, they put the tent up for him to see. And he went, they took him, showed him I think they showed him pictures of the tent. And once he knew that tent was up, he just began the dying process. And that can take usually about 72 hours uninterrupted. It's just, that it's about what it takes once they start into that process. And once he passed, they actually had his service under that tent.
Oh.
And that just meant so much to me because he had been such a leader of his family. But he told them, this is what I want you to do, and this is what you're going to do. I mean, he just led them all the way through that to the very end. And I just have such a respect and honor for him in the way he did that.
That's awesome. You mentioned good death earlier. What's your definition of a good death?
Comfort and asymptomatic with family and unity, and their spiritual desires met.
Gotcha. So asymptomatic, you can do that?
Oh, yeah.
That's
You
our
can
goal.
get them pain-free. You can work with their breathing.
Nausea.
Yeah. You have some diagnoses, though, that when I was a case manager, like you would shudder when you would see them because you knew it didn't matter what you did. They probably were going to have a rough death. And so you tried everything that you could to get them as comfortable as possible, for as long as possible.
What's a rough death? What?
Rough death is a lot of what we call terminal restlessness. So at the end of life, that's when, I don't know if you've ever, patients will reach, and I would love to know what they see, but usually they're unresponsive at that time. They'll try to get out of bed. They'll cry out. It doesn't matter how much pain medicine you give them. There's nothing that you can do. These are the ones that we would transfer to our inpatient unit, and we would do what we call palliatively sedating. So you're basically putting them into a coma because nothing that you can do in the field is getting them comfortable. Pancreatic cancer is one that's really hard. ALS is one that it's a rough diagnosis.
Some of our liver diagnosis
Yes.
also, you'll have a bleed out.
Mm-hmm.
The clotting disorders don't work anymore, and the patient literally can hemorrhage to death in front of their family.
I had a-
inside, or does it
comes
come
out.
external?
I had
My
a patient
goodness.
one time that we had, and it was one of those as a hospice nurse, I say in the field, we're the MacGyvers of nurses because we don't know what we're walking into half the time, and we only have a limited supply with us at any time. And I had a patient that we had for dementia, and his wife called me and said, he's just not acting right. And I was like, okay. She said, he's coughing up blood. And I was immediately like, oh, he shouldn't be doing that. And so I was luckily minutes away, and I went in, and I love this little guy. He loved to yodel. He would yodel all the time, and he was confused, but he was like the cutest. He'd sing me Conway 20 and he'd yodel. And he sat straight up in bed, and he must have had what's called a AAA or something, and it ruptured, and he bled out.
Oh.
Right in front of me and his wife. And she's saying, I don't know what to do. What do we do? And I had to say, we can either call 911 or we can just let it happen. And she was like, don't call 911. Like, if it's his time, it's his time, and after the fact, we got him cleaned up and pronounced him. But I was lucky in that case that she was as realistic
She
with
was there
where he needed to be. And she had said, my husband's been gone for 3 years. And she still calls me. He was a contractor, but he would hide things all throughout the house. So she remodeled a room and found like a ton of money that he had hid in the wall. And she was like, this might not be such a bad thing. But yeah, I mean, it was just, that was one of those moments, even as a nurse, that I was kind of taken aback and was like, this was not what was, I was ready for today.
Have you ever had a spouse just hug you and say, thank you? I'm so tired.
Yes.
Because I imagine, like, we talk about the people dying and it's sad and this, but the rock that is trying to hold things together, I think that people sometimes literally hold on too long and it actually depletes their life at the same time.
Well, we have that happen quite often. Caregiver fatigue.
Yes.
Followed by death. We had a situation a couple weeks ago where the husband was the caregiver and he had a massive heart attack and I think, and passed away before the hospice patient did, because caregiving is that hard. That's why, like she was saying, like Kelly was saying, it's not always possible at home. In order to have a good death, you must also have a caregiver and a support system to keep the patient home. Because once that breaks down, we can't do care. We are allowed to do hospital hospice, nursing home hospice, assisted living hospice. Basically, anywhere the patient lives, we can provide hospice for them, but they do have to have a caregiver. So that is a very important role. The other thing that came to me also is in my area, because of the opioid crisis and the things that goes on in our world in Southern West Virginia, is the increase of hospice patients that are under 40 with liver diagnosis from what we've seen in the drug epidemics. Those folks often have the tendency to bleed out because they just stop clotting. So I see more and more every day of self-induced, if you will, terminal diagnosis.
We talked about that at my job the other day about how many 55 and under patients we're seeing. And so then you have to think about, they have young kids, they have parents that are still alive, and so you're dealing with so much loss. But going back to the caregiver fatigue, our hospice is able, because of our inpatient facilities, to offer 5 days of respite every month for those caregivers. So if let's say I have a loved one at home and I'm just, I can't do it anymore. I'm physically drained. I can send my loved one to one of our inpatient facilities for 5 days. They're provided around the clock care. We feed them, we continue their meds as you give them in the home, and it gives you a break to just be able to rest in those 5 days. And then, so you get that 5 day break and then we send them back home.
Okay. How many of those 5 days breaks do you get? You
get 5 days every 30 calendar days.
Every 30. Okay.
Yeah.
That's good to know. Cause I'm sure there's a lot of people out here, West Virginians are hard-headed in a great way sometimes, but times like this, you have someone you've been with for 70 years and you have always taken care of things and you are trying to hold it together and the inevitable is occurring. How can we talk to those people and say, it's okay? This is actually better.
Yeah. I think it's just and it's hard because, like you said, we are stubborn. And one good thing about Appalachia, we take care of our own for the most part. I love the family dynamics of a lot of our rural patients, but sometimes it's just talking to them, and especially at end of life, I would say, why don't you let us step in and do the clinical part, and you just get to be the wife at this point. You just get to sit and love on him and hold his hand and give him kisses and whatever it is. You can watch your favorite shows together, but you let us focus on the medicines and the cleaning him up. And sometimes when you put it that way, you're not saying you're not doing a good job, you're not a good wife. You're saying you're such a good wife that I want to honor you and let you just be in that role for right now.
Yeah, I love that.
Yeah.
That's good.
do you ever run, like, because we do have some rural areas, especially in McDowell County. Do you ever run into issues of like, well, the power hasn't been updated in this house for like 40 years. We can't hook up this machine or anything. Do you ever run into that?
Yeah. If you're not complacent, I mean, if your house is not conducive to care, then that is one reason we cannot take the patient. Just because the patient has to have heat and water in order for us to provide good care. So we have seen situations like that. What we tend to do is try to work with DHHR to get them some help in there. We also have a fund set aside in our agency for things like that when we can help. If you ever read the obituary and it'll say, in lieu of flowers, please make a contribution to the Amedisys fund, whatever, that's where that money draws from to try to help. But certainly we would have to call on APS, which is Adult Protective Service, to come in and help us because they have many more resources than we do. Our social worker would take the role in that, and she would run that all the way up to find out what we could do with that patient to make sure that their needs were met. We often see that. We went in a patient's house one time and the patient was sitting under the ceiling that was ready to fall in on him. And there was no place else in the living room. There was like a heating stove, like a wood stove, this chair and another chair. And that's all as big as that room was. So we had to, move some stuff around, get some things going. Heat is another thing. They may not have heat in their house. And of course, we can't take care of a patient that could potentially freeze to death. So we just work with the system to make sure and to help them make it conducive for care. It's not always. There are people who promise their parents, I will never put you in a nursing home. And that's something we probably shouldn't do because we don't know what's going to happen between now and then.
See, let's talk about that because this is how I feel. And everyone's different. Like I've heard you better not put me in a nurse home, this and that and stuff. How I want to live my life personally is I'm going to try, who knows what curves you go through, but I'm going to try to have everything set up to where I have a stage of a plan. Like this age, we're going to do this if we're still doing good. This age, we're going to downsize the house. This age, we're going to look into some home care and try to base everything on allowing my daughter to just be there if she wants, if she can. Of course, I'd love to see her, but at the same time, as people grow, they live their life and they're building a plan of their own. You know what I mean? So I'm curious what your all's thoughts are on that for people who are. I mean, I hate to call it selfish, but, people want to help, but at the same time, sometimes some people work 50 hours a week to pay the bills. Sometimes people do certain things that just don't allow that to happen.
Yeah.
So what are your thoughts on that?
You get a lot of guilt from those family members who have made the decision that healthcare facilities are the people who are going to take the lead. There's many times that patients are much better cared for in a facility than they would be at home without the right support system. It's not one-on-one, and I try to tell people that all the time. Skilled nursing facilities are not one-on-one. I mean, there might be one person to 20 people. I don't know the ratio, but it's definitely not one-on-one. Do they get better care at home? Yes, but one person cannot do that. There is not one person that around the clock can meet the needs of a patient. You need an army to help that. I think facilities do a great job. And I've seen them do great jobs. Nobody wants, 87% of the population want to die at home.
Yeah. Oh, that's a fact?
That's a fact.
Oh.
Only 34% get to die at home. So
nice,
we have a long way to go, don't we? We have a long way to go.
No, yeah, that's interesting to think about. And I can believe that too. I mean, it's like you said, you don't really think about it until something tragic happens. Or, some people don't have a chance to think about it at all. They're in some kind of accident or something happens. So yeah, I want people to don't be too hard on yourselves, but also don't be too hard on your kids. If some kids are jerks. I mean, I think we all know that.
I was going to say my only thing is not everybody is cut out to be a caregiver.
Mm-hmm.
There were 4 of us kids, and I know that not all of my siblings would be okay, with wiping butts and feeding and doing, and that's okay. My thing is, if you do put them in a facility, be their eyes and ears, visit them, make sure you are present, because what breaks my heart are these families that put their loved ones in a facility and then they never go check on them. They never, it's
sad.
Like out of sight, out of mind.
Right.
And that's when I'm like, I have an issue with families that do that.
Yeah, that's very sad.
Mm-hmm.
And if you team up with hospice in the facility, all the more reason, because you have more eyes in there, more people looking at the patient, more people talking to the family about the patient and whatever.
Yeah.
So, I mean, but I'm working on a situation today where they promised mom, you'll never have to go. And that daughter's having a horrible struggle, but life has dealt her such a hand that there's no way she can take care of her mother. And the grief alone of having to do it is just, I think we should all be sensible when we're making these big decisions about that, and to say, I want to take care of you until I can't anymore, or until I can't give you the service someone else can. But I think we just all want to say we're never going to a nursing home. But I've really seen some good outcomes. Stay vigilant, stay connected, be a part of that facility and what they do. Ask questions, call it unexpected times.
Yeah.
And there's a lot of great facilities out there. And a lot of them are full. One comes to mind. I've worked with Princeton Healthcare Center. Great people.
Yes.
Amazing work that they're doing. So, but also I'm curious. So you mentioned working with APS. So you all work with state systems sometimes. Have there been times where you're like, there may be some abuse going on here?
Yes.
Like, what do you do in those situations?
I had one situation that, went in a couple times, and it was like that spidey sense. You just know, like, you're not sure what it is, but you just know something is not right. And so I called the CNA and said, when do you normally go? She told me, and I said, we're not going. We're going at a completely different time. We're kind of going to ambush them. And I walked in to basically a house of horrors. And I had a patient handcuffed to a bed, had probably not been changed since the last time our CNA was there. And so I called Charleston Police Department and immediately had her transferred to one of our inpatient facilities and started an adult protective service, call and case or whatever. I luckily have only had to call APS, I think 3 times in my, 6 years with hospice. But sometimes it's as easy as going in very early and saying, this is not okay. We are kind of big brother in this situation, and we're going to keep an eye on them. And a lot of times the families will straighten up, but every once in a while, they're unfortunately keeping mom or dad or whoever in the house just for a paycheck. And so they're doing the bare minimum.
So that's the reason, getting their benefits, going out, doing what they want with it. And then, okay. And then they kind of tidy up when you come.
Right.
Gotcha.
Yeah.
We don't have so much APS cases as far as abuse, but we do have a lot of drug diversions. People know when the hospice team comes, you're going to get some medicine. And we've had several individuals show up at the same, like we go to do an admission and Sally was going to be his helper, then their helper. And then the pattern of that, those narcotics have to be counted by our nurse, and they'll be gone, caught on fire. They rolled in a river. Somebody broke in and stole them, and all of it is part of someone else taking the patient's medicine. So we can't control the pain. They're calling at 2 a.m. saying, mom's in pain. Well, where's mom's medicine? So we do have a lot of that in which we have to involve legal folks in from time to time. But we are all mandatory reporters. So all of us are required to report to APS, to CPS if the child's in danger, or to the police.
Okay. We've talked about that a few times on the show, but let's talk about it again. So that's basically, are you liable if you don't say anything? Is that basically what that means? Okay.
If you had knowledge and you did not report that, then certainly you could be in question for that. One, who would let that happen and know it's happening? You would be guilty, in my opinion, as anyone else if you knew it and you didn't say anything. So, yeah, and we do have a social worker. So if we see something that's not right, our first step is to call our director, our clinical manager, our social worker, and say, "Hey, this is what I witnessed." And then they actually pretty much. But myself, have I made them? Yes. Would I today? Yes, absolutely. Because a lot of times APS can help. They're not just there to take a patient or whatever. They actually have some great tools that they can help them with. So,
sometimes we get patients that are guardians of the state too.
Yes.
So it's basically like if a child was in foster care, we have sometimes mentally disabled, or maybe, an elderly person whose family has financially drained them, things like that. We also go back to the abuse. I know with hospice care, if we get a patient and they have injuries that can't be explained, we will make them a medical examiner case. And so if they pass, we want to know that they died from the diagnosis we had them from and not from some other, whether it's a head injury, possible abuse, So if they have bruises, but they haven't had a recent fall, or they just have injuries that we can't quite explain, and a lot of these are direct admits or things that, maybe we are just now getting them, we will make them a medical examiner case.
Gotcha. And I wouldn't mess with y'all. I feel like y'all would go get a softball bat out of the trunk or something.
probably not good.
Yeah. All right. Let's talk about, I want to stay on this abuse part because there's been cases, in West Virginia at some homes where people put their family member in a nursing home and there have been signs of abuse and there has been abuse. It's rare, thankfully, but it happens. What are some tips that someone can look for with their loved one to be signs of that there may be potential abuse going on?
You mean in like a long-term care facility?
I mean, either that or like, Larry's taking care of mom and I don't think Larry's doing a good job. Like any type of signs like that.
I would always make sure you don't want the patient to look disheveled. You want to make sure they're being bathed. A big thing for bedbound patients, they're not getting bed sores, that they're being turned, that they're being, if they're soiling on themselves, they're being cleaned and they don't have, adults even can get diaper rash, weird bruises or skin tears, things that just don't. Now, it's not uncommon to go pull somebody up in bed and your ring catches their arm, or and we always make an incident report because we want whoever it is that comes in behind us to know, oh, Kelly said, her watch caught Miss Smith's shoulder and left a mark or whatever. But just, if somebody is just going about their day-to-day life and they're not having falls, they shouldn't have bumps and bruises and
excessive.
Yeah, exactly.
Gotcha.
They shouldn't have skin breakdown. They should be clean. A big thing, I know our CNAs, want to pull their hair out when they go in nursing homes, and just these places sometimes won't wash behind ears and belly buttons, under fingernails, mouth care. These are all, really important things that sometimes people don't do for these patients.
Gotcha. And they're old and feeble, and some are on blood thinners, and people bruise easier than others. So you got to kind of weigh all that. But at the same time, like, watch the rashes. Bed sores is what basically, like, that's where they don't move from a certain spot.
It's a pressure ulcer. So basically any bony prominence is putting pressure. And so the bone actually starts to break down through the skin, and you'll see what looks at first like a bruise or a blister, and then that opens up and gets worse and worse.
I think financial
Yes.
exploitation is really to be exploited financially is one of the biggest abuses that we see. The families giving bare necessities to the patient while taking their finances. So dad didn't get his medicine, or we can't afford diapers, and I think that I don't think one person should ever be responsible solely financially. I think if you have 3 kids, that should all be something the 3 of you need to be answering for, because it happens way more than it should in people's homes. So hospice comes in, like say we're paid for by Medicare. There's no money expected. So we often get called on those things where the finances are not being cared for correctly.
That makes sense. Does this typically happen for like nonverbal patients versus others, or
it could be all.
Could be all.
They're at the mercy of the caregiver. I mean, I've honestly, I've witnessed a patient getting 3 pain pills a day and give her son one of those pain pills because she needs him to be functioning to help her. So they say less and less because they're at the mercy of that caregiver. So financially, they are often exploited.
And sometimes you could just be in the room with it. Like one of my biggest pet peeves is when the family members snap at the patient or talks down to them, especially dementia patients. And I understand my grandmother had dementia. Sometimes you're at your wit's end if you've worked, but when it's a continuous thing, we'll have a talk with them, and it's just not okay.
So you'll sense a vibe sometimes. It's like, this ain't.
Yeah.
Okay.
Yeah. Or sometimes I'll tell you the biggest red flag is when things are almost too perfect. When they have an answer for everything. When it's almost like they talk too much and you're like, you're trying so hard to get me to like you and believe you that I'm seeing right through this facade. And so sometimes those are the ones that you're like, no, I don't believe this at all.
Yeah. That's all good to know. I hope that helps somebody out there. How many patients have you saw over the years, Michelle? I'm curious about you too, Kelly. But
oh my goodness.
I don't know. I have no idea.
So many.
I have a book at home that I have written down every patient that I've seen, what their diagnosis was, how long I had them.
Every patient?
Wow. Yeah.
Okay. Which, 6 years you said? Okay.
Yeah. Yeah.
How many would you
and
say?
So for a case manager, we have usually a typical caseload is 14 patients per case manager, and that can go up or down. So the crazy thing is sometimes those patients last a day, sometimes they last 6 months. Hundreds of patients. Yeah.
Yeah. Same with me. I mean, it's thousands of patients that we've had the opportunity to serve. And I'm always careful and to make sure that they understand that hospice is a gift. People who get killed driving their car, they don't get that gift. People who are murdered, they don't get that gift. So when hospice is introduced, it's literally a gift. And every day you have with that loved one is part of that gift. So we offer the gift of hospice, and it's truly that from the beginning to the end.
Heck yeah, I love it. All right, hardest question for last. Where do we go when we die, ladies? Let's solve it right here. What happens? I trust y'all's opinion above most people's because y'all are part of this process.
Well, what we can see with our eyes is during the end stage, you'll start seeing what we call the rally. And the rally is when the patient wakes up one morning and is completely normal. They look like they did 10 years ago. They order up a large breakfast. They want to see Mary and Billy and all the people. And that is the scariest part of hospice.
Because the family will be like, they're getting better.
Yeah.
So we warn them about this. I had a patient that hadn't walked in 5 years, got up and walked from the bedroom into the kitchen 2 days before he died.
Yeah.
Yeah.
And it is all full of false hope because they're like, get them off hospice. Daddy's walking. Call hospice. Tell them we don't need them anymore. But that is actually the surge of energy that they need to get out of here. So they get this surge of energy. And in that time, they have an opportunity to say goodbye. And they'll sit on the porch, they'll wave, they'll drive the car, they'll get in the car and drive down to the milkshake place.
They'll drive down?
No, they'll ride.
Okay,
but they're
I was gonna
still in the
say-
car.
Some of these little old men, they may want to drive.
They probably will. But that'll last a very short time. And when that happens, that patient settles into death. It's almost like birth.
Mhm.
They get very quiet, very disconnected. And that's when if you will allow them, then they'll continue to go right on out of here. How often does that happen? A lot of people stop giving their medicine during that time. And then the patient goes into pain crisis. And then we have to start all over again to get them comfortable enough to go. But basically, my patients on a good death, they just literally stop breathing. They just take a breath like they're asleep, and they never know. They never know it's over. They would just, my grandmother, they told her she would have a horrible death because she was respiratory and that she would smother to death. Now, what doctor tells a patient that? I'm not sure, but that's what they told her. That was not true. In the last hour, she asked my mom, do I have to wear this anymore, her oxygen? And my mom said, not if you don't want to. And she said, I don't want to. And mom said, okay. She took it off and she lived probably 2 or 3 hours. She never breathed one hard breath, and she rolled over on her side and she just went to sleep, and that was the end of it. It happened that easily. I do know that there are, I don't know. I've not died before. I haven't died. There is the anxiety involved in that, I'm sure. We do use a lot of Ativan during that time just because of anxiety and to help relax muscles. But they say you're stuck somewhere between here and somewhere else, and that gets confusing, almost like you do when you wake up from surgery, when you're real sleepy, but you kind of think you're here. And so that's when the agitation comes in. They can't promote into one place and they can't come back to here. So they're just kind of hung there until we can get them comfortable. But for the most part, I think where they're going is secured by them before they go. I think they know what their belief is, what their faith is. I think that carries them right on into whatever it is that I can't see.
I love this conversation.
Yeah.
What about you?
I don't know where we go, but I've had so many patients that are so happy about it. I can only imagine it's a beautiful place, Like she was talking about the rally, my grandmother had advanced dementia. My husband and I sold our house, moved in with her so we wouldn't have to put her in a home. And she had known who I was for probably 4 years. And 2 days before she died, I was walking through the living room and she said, well, Kelly Ray, when did you get here? And I knew. And I just turned around and said, well, what are you doing? Made her favorite meal. I called everybody in the family and was like, if you want to say goodbye, you better get here. And of course, I had some family members that were like, I told you she wouldn't die. And I'm like,
Trust me.
But she bawled and cried and said, it's so good to have my whole family here. And she said, I'm gonna go see mom later. And my grandfather had come to get her the night before. She got up and said, Ulysses is here. He wants to take me home. And I said, well, he's already left. Let's go back to bed. And so I told her, I said, I bet Papa will be here tonight to get you. She went to bed that night, was unresponsive, and died 2 days later. And so whatever it is, it must be beautiful. Yeah. And I hope that everybody we love is waiting for us. That's the only hope we could have.
Heck yeah. Let's put it in one word, somewhere.
Yeah.
I love it. All right. Let's talk about where each one of you all work, how someone can get, hospice involved in their life. Kelly, since you were talking, go ahead and go first.
So at HospiceCare, anybody can make a referral. If you thought your mom, and you were in one of the counties that we serviced, you thought your mom, your sister, your neighbor might qualify for hospice, you just call our number and they would put you through to one of our referral coordinators. They'll get all your information. They can contact your doctor. And they can get those medical records. And then within 24 hours to 48 hours, one of our assessment nurses will come out and do an assessment. If you don't qualify for hospice, we can refer you to palliative. And that's a whole nother topic. Palliative is a huge service in our area that I don't think people utilize enough. And that's when you're still seeking curative treatment, but you want kind of that support that maybe you're not going to get 100% better, but you're not quite ready for hospice yet.
Okay. Yeah. Palliative care is part of it. So that's good for people to know.
Mm-hmm.
I'm going to put pressure on you. What's the phone number? You need me to look it up.
It's 304-768-8523.
There we go. And the name of your specific organization?
It's HospiceCare.
Is HospiceCare.
Yes,
this
right
one right
there.
here.
Mm-hmm.
304-768-8523. Okay, let's go. And you have a website?
Mm-hmm.
I'm sure.
We're high tech. Look at that.
Yeah, look how you fancy. That's fancy stuff, Kelly. What about you, Michelle?
Amedisys Hospice, Bluefield, West Virginia. And we do have a website. It is actually, hospice is provided by Certificate of Need counties. So we are McDowell, Mercer, and Wyoming County. If the patient lives there, gets services there, then truly we would be more than happy to serve them. Our number is 304-327-0600. On our website, you'll see a place where you can answer a few questions, and they'll send that right on through to our intake, and we'll get a look at that as well.
Look at y'all.
Yeah. So
let's get them a raise. They knew all that off the cuff. You didn't even have to ask them. I don't know any phone numbers. I don't even know my phone number.
The crazy thing is hospice has only been a thing for about 50 years, and that is worldwide.
Right.
And so that's just crazy to me. I'm almost 50, and I'm like, how it's sad to think that people weren't being treated, correctly before then.
Oh, yeah.
And,
so as far as a career, of course, y'all may be biased, but someone who is going into college thinking about doing this career, can you make a good living? Is it rewarding in that sense plus the emotional sense, or do you have to have a certain, foundation coming in of knowing you can do good, but this is really what it's about? Does that make sense? You're not getting in to get rich necessarily, but you can still take care of yourself. I don't think
any of us do this for the money.
No.
And hospice nurses do not make what you're going to make if you work in ICU or you're a travel nurse or something like that. But one amazing thing I know, for our facilities, is most of our nurses don't work nights. They don't work weekends. They don't work holidays. And just the reward of the families that I have touched and that have been and still are such a major part of my life. There's no money in the world that could make up for that.
Yeah. Michelle, you've been doing it for a little bit. What do you think?
I do think it's a calling. I think there are people wired just to do this job. And I'm never upset, if we get someone that goes to lunch and don't come back. I just know that wasn't their calling. And it's best that we wait on those who are called to do this. They say all the time, oh, you're our angels. And our team calls before they go out every morning, so the family knows that we're coming that day. If our nurse fails to do that, we get calls from the family who are worried about the nurse. So it is a two-way street. They are as appreciative and love us as much as we appreciate taking care of them and love them back. After the service, 3 months, our best customers go, they're not here anymore to tell the testimonial. So we send out a little report card 3 months after the passing, and we say, how did we do? The one thing that is said over and over is how I wish I had known about you sooner. So that's our mission, is to make sure that people know sooner. If you don't choose hospice, that's completely up to you. I just want you to know you could have.
Right.
And that's my job.
Yeah. You ever walking in Walmart and someone's like, hey, Michelle, I just want to thank you for taking care of Granny.
Yeah.
It was really,
I see them all the time. And I can't remember that many faces, but they never forget me. They never forget their nurse. They never forget their chaplain, and their experience. And that is truly what's helping us in the hospice world, is the satisfied people who walk away and say, no, don't be afraid. My dad had hospice and it was great. So keep up the good work, sharing the testimonials about hospice, and let people know, it's an option. If you do not like hospice, you can sign off. You're not stuck with us at all.
Yeah.
So I always say, if it doesn't cost anything and you can return it, why wouldn't you try it? And, a lot of times I say, just give it a 2-week trial. If you're not happy, then I'll come back in 2 weeks and you can sign right back off and be right back where you are today. Very seldom do I have to do that.
Yeah.
I love, even if I have my hospice badge on or a shirt, even if I've never taken care of them. And I know my kids are probably like, oh, here she goes again. But people love to tell their family's legacy and how hospice touched them. And I love to hear those stories. That's like when I would go in and take care of my patients. Show me pictures of them when they're young. I want to know who I'm taking care of.
Yeah.
Not the 98-year-old that's in the bed. Show me when he was in World War II. Show me when he worked at DuPont or whatever it was. And I say all the time that grief is love's echo. And the louder you love somebody, or the more you love somebody, the louder that grief is. And talking about them and telling their story is just remembering them in the most amazing way. Yeah. And so I love when patients say, hospice was amazing. And if we weren't amazing, I want to know that because I want to know how to fix it. Yeah. What happened that you weren't happy, because we want to make sure that never happens again.
And sometimes the unhappiness comes from the very fact that they were just not ready to let go.
Right.
And the worst patients, the most unhappy patients I have are the ones that felt forced. Mm-hmm. You have to take hospice to go home. Mm-hmm. You can only go home on hospice. No one likes a forced sale.
Right.
No one. And those will be your patients who are really unhappy.
Yeah.
I find that to be true. The people who've come to the agreement that, yes, this is what we want to do, they're mostly always satisfied.
Yeah.
So it is that. The other thing we didn't mention is bereavement services. We have 12 months of bereavement services following the passing of the patient for the family. Mm-hmm. So we're there the first birthday, the first anniversary, the first Christmas, all of that stuff. You're going to hear from the hospice team for that caregiver, the people who took care of the patient.
Oh, that's beautiful.
Yeah.
We have a memorial one time a year where we honor our patients that have passed as a staff.
Oh,
yep.
That's so cool. Is turnover high?
Yeah, it is.
Yours is? Mm-hmm. Not yours?
No.
So it may be, because we got two different counties here.
Right.
So Kanawha is definitely different than McDowell. So it's good to know that, like,
our drive time.
Right.
McDowell County is 454 radius miles.
Yeah.
It's a big county with only 20,000 people in it.
Yeah.
So you have to drive and drive and drive and drive from one patient to another patient, where in the city or in a different area, you would only be driving a short distance of time. So the drive time is tough for our nurses. Being 2 hours away from the end of our county is a big deal. Yeah. So again, you got to love it. You got to love it to do it. Pay comes second. Hours come third. You just work when they need you. You just do it. And it's very rewarding.
Well, yeah. Now I love driving McDowell County, but you get a patient. Okay. I got one patient in Mayberry. I got one patient in Bradshaw. Mm-hmm. And you got to go there on the same day. That's a problem.
Yeah. Or the same night.
Yeah. Same night. Yeah.
I will say our nurses are lucky. Like I said, we cover 16 counties, but we have multiple nurses. Like our Lewisburg nurses, we have a handful of them. Our Summersville or Nicholas County nurses, right now we have 2 RNs and an LPN. We have a nurse that covers Clay and Braxton. We have, so I will say we are very well staffed. Most of our nurses have been there 10 plus years. Usually when we have turnover, it's because of retirement, or like we had a nurse that just had a baby and had the opportunity to stay home. And I don't blame her at all. So those are the reasons that people leave our office.
I got you. And I got another, we're just going to keep going. I have another question. How'd the pandemic affect y'all?
We didn't stop seeing patients. We kept seeing patients. We just kept going right through the pandemic.
Really? Just same. Did you just wore a mask?
Oh, yeah.
And that's a hard thing. I actually got hired in the peak of COVID. It was March of 2020.
Congratulations.
So it was like basically like a drive-up orientation that they handed me my stuff and they were like, we're going to have to do this over Zoom. Yeah. So that was a little scary. But I would say the hardest thing about the pandemic is trying to convey what we need, and all you can see is this much of our face.
It's like beekeepers.
Yeah. And I remember one time I had a patient and he knew that he was probably going to pass over the weekend. And wasn't going to be on. And so I was telling him I loved him, and and he said, before you go, will you take your mask off so I can see who has been taking care of me? And it was like, it hit me at that moment that he knew my voice, he knew my eyes, but he didn't know anything else. And so I pulled my mask down, and he was like, well, you're not as ugly as I thought you were. And I was like, well, thanks so much.
That's great.
But, so that I think is what made it hard.
Yeah.
We actually lost one of our nurses during COVID, with COVID.
We did too.
Yeah. So it was traumatic for our team, and those folks, they amaze me. We have a CNA that's been with us, I think, 16 plus years. They just keep going because someone needs them more than they need anything. So they just kept going. I mean, it wasn't hard. I had one patient, one of the nurses had a patient, and the lady wouldn't let them in the house because they had all that on. And she's like, I'll stand at my window and you can look at me here, but you're not coming in my house looking like that.
We had some patients that would make us call, but we actually lost a nurse during due to COVID also. And there's actually a law now called Melissa's Law because she had to die alone.
Oh,
and
really?
so they fought saying that no one should die alone in the state of West Virginia. And so, I hate that we lost her, but I love that her memory lives on in something, that beneficial.
Things. Like people who lost people with COVID, I mean, it wasn't just that. They couldn't have a service.
Right.
They couldn't see them.
You couldn't donate your body. That was a huge thing. A lot of our patients rely on like body donation to universities and things like that. And you couldn't do it, and they couldn't pay for a burial. And so that was rough.
It's sad.
Yeah.
So sad. Well, thank y'all for what you do. You said something, grief is love's echo. I'm going to get that tattooed tomorrow.
I love it. Yeah, I absolutely love it.
That's a good way to end this. I appreciate you all. Amedisys Hospice and HospiceCare. Shoutout. And there's others too. Hospice of Southern West Virginia is one of them.
There's Dignity Hospice.
Yeah. You can Google it, hospice near me.
Yeah.
And it's going to come up.
Hospice of Huntington. Is
They're getting their own DoorDash app, I heard.
Yeah.
They're going to.
There we
to bring the medicine.
Oh, no. Thank you all. I appreciate you putting up with my jokes, and I love that you all explained everything so down to earth. You're very intelligent, and thank you for taking the time.
Thank you for having us.
Everyone else out there, be sure to like this video before you leave. Subscribe to Creepalachia on YouTube if you haven't. And if you're listening to Apple or Spotify, take a minute and leave a review. That'll really help the show be found. And we are on Facebook, Instagram, and TikTok. And we do have merch now. We're about to release hoodie pre-orders, Creepalachia.shop. And everyone else, always remember, above all else, long live Appalachia.